Good morning, everyone. So the Division of Endocrinology will be presenting on a very important topic. Exogenous Cushing syndrome is an iatrogenic disease, and we want to bring some awareness to its complications and management principles. So endos have a love-hate relationship with cortisol. We love the hormone. We think it's vital to life. We think everyone should have it, but we're always extremely reluctant to prescribe it. So Dr. Sadiya Nanabhay will be taking us through some of these challenges. And as of tomorrow, Dr. Nanabhay is a fellow in endocrinology. Congratulations, Sadiya.
Good morning, everyone. I'll be presenting a case called Too Much of a Good Thing. So starting with our case presentation, we have the case of Mrs. MD. She's a background hypertensive and dyslipidemic. She's been hypertensive for the past 10 years on 2 agents and dyslipidemic for 4 years on simvastatin. She presented to our emergency department on the 15th of January with a history of a syncopal episode and associated nonspecific chest pain. At this point, she gave no history of respiratory symptoms, no symptoms of heart failure, no history of any palpitation or previous angina. She did give a history of 3 weeks of nonspecific symptoms such as malaise, nausea, and nonspecific muscle pain. In terms of her past medical history, she's a mother of 2, no previous miscarriages. However, she's been amenorrheic for the past 10 years with no prior workup. She also has no prior history of contraceptive use. She does give a history of significant use of skin lightening creams for many years over her entire body, but predominantly her face. She denies any other medication, and this was on numerous probing attempts and no history of thrombotic events previously. So on examination, she was tachycardic with a heart rate of 110 beats per minute. On general examination, she had typical moon facies, facial plethora, dorsocervical hump, truncal obesity, multiple stria on her abdomen and arms, ecchymosis on her limbs, as well as aganthosis nigricans. Her systems review was virtually unremarkable, but of note, she had evidence of mild proximal myopathy on neurological exam. So at this point in casualty, she was assessed as a 44-year-old female, background hypertensive dyslipidemic, with features in keeping with the Cushingoid appearance, now with a syncopal episode and nonspecific chest pain. The primary differentials now were that of a pulmonary embolism or an acute coronary syndrome. In terms of her investigation, her full blood count, kidney function test, liver function test was normal, her septic markers were flat, 2 times troponin T levels were negative, and a pro-BNP was negative as well. Her D-dimer was raised at 0.62, and she was newly diagnosed diabetic with an HbA1c of 6.9%. Her chest X-ray and ECG were unremarkable. And in view of her nonspecific chest pain, sinus tachycardia, as well as a raised D-dimer, a CTPA was done, which ruled out a pulmonary embolism. So at this point, endocrinology was called for evaluation of a Cushingoid appearance. As you can see, the first picture shows her moon facies. You can see evidence of a dorsocervical hump, ecchymosis, as well as significant stria on her arms. These are more than 1 centimeter in diameter as well. As mentioned earlier, she did give a history of long-standing topical steroid use, but denied any other forms of steroid use as well. So over here, you can see this picture quite nicely depicts the cosmetic onchronosis, which is typically seen in patients using topical steroids. On further interrogation, Mrs. MD eventually admitted to oral steroid use. She had significant use, 20 milligrams of prednisone daily for over 5 years. She was using this medication, she was buying it over the counter. She claimed she initially started using it for nonspecific joint pain, but continued, and it just overall made her feel good. And at this point, thus, the diagnosis of exogenous Cushing's was made. So this brings us to our topic of today, which is that of glucocorticosteroids. Virtually every discipline of medicines uses steroids via multiple modes of administration, and they have remained the cornerstone agent for treating a wide array of medical conditions. So from autoimmune diseases, inflammatory conditions, allergic reactions, to the prevention of transplant rejection as well. So a good understanding of it is imperative. Just to revise the physiology, we know that steroid synthesis is controlled by the hypothalamic pituitary adrenal axis. So the hypothalamus will release corticotropin-releasing hormone. This will then act on the anterior pituitary, which will produce adrenocorticotropin hormone. ACTH will then act on the adrenal cortex to produce cortisol. So with reference to the diagram on the right, we know that the adrenal cortex has 3 zones: the zona glomerulosa, which produces mineralocorticoids, the zona fasciculata, which produces glucocorticoids, and the zona reticularis, which produces adrenal androgens. So we know that ACTH and cortisol are secreted in a pulsatile fashion, and this is important to remember when trying to interrogate this axis. Cortisol is the highest in the morning and will then steadily decline throughout the day. The average ACTH pulse frequencies is higher in normal adult men compared to women. So men will have about 18 pulse frequencies over a 24-hour period, and females around 10. There are various factors that will influence cortisol release. And again, this is important to remember when evaluating this axis in your critically ill patients, such as ICU patients. So pro-inflammatory cytokines, physical stress, fever, surgery, burns, hypoglycemia, and hypotension can all increase cortisol release as well. So once cortisol is actually released into the bloodstream, it needs to bind to a transport protein. So 25% will bind to albumin, and the remainder will bind to transportin, also referred to as corticosteroid binding globulin. In states where you have low albumin, such as nephrotic syndrome, you will have increased amounts of free glucocorticoids, and that will result in a higher side effect profile as well. And synthetic steroids do not bind well to corticosteroid binding globulin. So prednisolone will bind with affinity of 60%, prednisone 5%, and methylprednisone or dexamethasone less than 1% as well. Just a note on the terminology. So when we refer to steroids, it's quite a broad term, and it encompasses corticosteroids, which is glucocorticoids, which is our topic of today, and mineralocorticoids, and sex steroids as well, which includes progestogens, androgens, and estrogens. So in terms of the drug interactions, we know that exogenous Cushings are subjected to the same hepatic oxidation, reduction, and conjugation as endogenous steroids. And any drug that affects the cytokine P450 activity will affect the activity of our steroids. So inducers such as your anti-epileptic agents, antimicrobials like rifampicin, which we use very commonly, or antivirals like efavirenz, will actually decrease the activity of your steroid. And inhibitors such as antifungal or antimicrobials like clarithromycin will increase the activity. This table just depicts common drug interactions. And common things to be aware of would be that steroids often can potentiate the effect of warfarin. There's an increased risk of tendon rupture when co-administered with fluoroquinolones, and increased risk of peptic ulcer disease when co-administered with non-steroidal anti-inflammatories. So there are many different types of steroids that are commonly used, but they all share key structural features. However, they are not the same. And the above table groups the commonly used steroids into short, intermediate, and long-acting agents as well. So in terms of the potency, we know that hydrocortisone is the least potent. Prednisone is 4 times as potent as cortisol, methylprednisone 5 times, and dexamethasone 25 times as potent. And in terms of the duration of action, dexamethasone has the longest duration of action, up to 72 hours, and hydrocortisone 8 to 12 hours as well. In terms of the routes of administration, there are various routes to administer steroids, and the bioavailability of synthetic steroids will vary by the drug formulation as well as the route of administration. So parenteral use, this will ensure critical delivery of the drug in your critically ill patients or in malabsorptive states. Oral is the most commonly used, acutely and chronically, and it takes approximately 30 minutes for the drug to be absorbed. In terms of your local use, this will ensure a high local concentration and aims to have less overall systemic side effects. However, it is important to remember that local use can have some degree of systemic absorption, and thus it can affect the HPA axis. So robust evidence regarding the impact of intra-articular steroids on the HPA axis is lacking. However, steroids have been found in the urine for months after the injection, so it does suggest prolonged systemic absorption. In terms of the adverse, In terms of the adverse effects, there's a vast array of adverse effects. So in terms of the neuropsychiatric effects, in terms of your mood, generally patients will report an increased sense of well-being when just initiating the drug, but with long-term use, there's an increased risk of depression. In terms of psychosis, this is more commonly seen at higher doses, so above 20 milligrams per day as well. In terms of the immune system, we know that there's an increased risk of infection, and this is because of the effect of leukocyte trafficking, the natural killer cells. It impairs phagocyte functioning as well, and impairs immunoglobulin. In the eye, there's an increased risk of glaucoma formation. In terms of your GIT system, there's increased risk of peptic ulcer disease. In our cardiovascular, it causes fluid retention and hypertension. There's increased risk of premature atherosclerotic disease as well. In terms of our bone, it inhibits osteoclast function, so it has an increased risk of osteoporosis. And in terms of our skin, it has a catabolic effect, which causes a breakdown of protein and collagen, resulting in skin thinning. And in terms of our endocrine system, it results in insulin resistance. You have an increase in your total cholesterol, your triglyceride level as well. It suppresses your thyroid axis, and it suppresses your GnRH, which will then inhibit your LH and FSH as well. So this is just a retrospective cohort study that was done from 5 Swedish healthcare registries, and it looked at the the mortality and morbidity in patients on steroids compared to a control population. So we could see here that your oral steroid users have an increased mortality rates compared to the general population, even after adjustment for comorbidities. And high-dose users have a 2-fold overall increased risk of dying from sepsis, pneumonia, and pulmonary embolism compared to control studies as well. I'm just going to elaborate on 2 common side effects that we see, that of being glucocorticoid-induced hyperglycemia, as well as glucocorticoid-induced osteoporosis. So hyperglycemia is a common side effect of steroid treatment, and it occurs in up to 30% of hospitalized patients. Typically, glucocorticoid-induced hyperglycemia has a characteristic pattern of postprandial hyperglycemia around midday and lower early morning and nighttime glucose values. So the ADA recommends that we try and aim to achieve a target glucose of around 7.8 to 10 millimoles per liter in our hospitalized patients. And we should try and keep it within this range, avoiding as many hypoglycemic episodes as we can. There's only scant evidence in favor of a more rigorous glucose control as well. In terms of our glucocorticoid-induced osteoporosis, we know that 30 to 50% of patients on glucocorticoids may at some point fracture. So who is at risk? So patients at risk would be those on higher doses of steroids, those with longer duration of steroid use, your elderly population, and those with your inflammatory diseases such as rheumatoid arthritis or inflammatory bowel disease as well. So this table just depicts data from the United Kingdom General Practice Research Database, and it shows that for patients exposed to high-dose steroids, so more than 7.5 milligrams per day, the 10-year probability of a major osteoporotic fracture was increased by 15%, and the 10-year probability of a hip fracture was increased by 20% as well. Okay. So how do we evaluate these patients? So patients should have a baseline screening. If you think they're going to be on steroids for more than 3 months, you should assess them for clinical risk factors as well as bone mineral density, which we normally use a DEXA scan. And then you should reassess for fracture risk within 6 months of initiating therapy as well. What can we do to prevent our patients from achieving glucocorticoid-induced osteoporosis? You should supplement them with calcium and vitamin D. You should try and aim to use the lowest dose possible, avoid smoking and alcohol use, and try and engage your patient in weight-bearing exercise as well. So we know that the adverse effects of steroids, there's 2 main factors, and that's being the duration of your steroid use and the dose of your steroids. So the longer duration of steroid use is associated with a higher cumulative dose and increased adverse effects. And in terms of the dose, the daily dose of steroid is a key factor in toxicity, with higher doses carrying a higher risk of adverse effects, and this is referred to as the linear effect as well. So the following diagram just demonstrates the time to develop serious adverse events in patients with rheumatoid arthritis, either treated with no steroids, so that's the yellow line, or with different doses of prednisone. As we can see, there's a linear association between the increase in your dose and the increase in your adverse effects. And we see more marked adverse effects at a dose of 7.5 milligrams of prednisone. So in terms of monitoring our patients on chronic steroids, what should we do? The first thing would be to assess for pre-existing medical comorbidities. So these are conditions like diabetes, hypertension, heart failure, obesity, peptic ulcer disease, and manage these conditions independently. And then in terms of your cardiovascular risk, a lipid profile should be taken 1 month post initiating steroids and then 6 to 12 monthly. Glycemic control requires assessment via screening for symptoms at every visit. You should aim to do an ophthalmology exam annually, and this is to screen for glaucoma. In terms of prevention of infection, if patients on a higher dose of steroids, so more than 20 milligrams for a prolonged period of time, so more than 4 weeks, they suggest to cover with PCP prophylaxis. And immunization should be offered to patients on extended courses of steroids. If a patient is on more than 20 milligrams, the MMR and live vaccine should be held till 1 month post stopping the steroids. Bone health we've already covered, and the HPA axis I will discuss a bit later. Not very relevant to our population, but steroid use will cause stunting of growth. So children should be monitored every 6 monthly, and their growth should be plotted on a growth curve as well. So a common side effect of long-term steroid use is exogenous Cushing's, which was seen in our patient, Mrs. MD. The signs of Cushing syndrome are often very non-specific, so they can overlap with conditions such as obesity or pregnancy as well. So the discriminating features that we look for Cushing's include facial plethora, proximal myopathy, cutaneous stria that is more than 1 centimeter wide, and bruising as well. The symptoms that are more commonly seen in iatrogenic Cushing's, that it being glaucoma and cataract formation, benign intracranial hypertension, avascular necrosis, osteoporosis, as well as pancreatitis. So in terms of the need for further testing, if you have a clinical suspicion of Cushing and the patient gives you a history that they've been on steroid use, there's no need for further testing. Testing is required for the likelihood and etiology of endogenous Cushing's. So we know that suppression of the HPA axis is an inevitable effect of long-term steroid use, and recovery of the adrenal function will vary greatly amongst different individuals. It's very difficult to predict, but we know that any dose above the physiological daily dose can potentially lead to suppression of the axis. And importantly, just remember that it's not only oral steroids, but all forms of steroids can suppress the axis as well. The Endocrine Society suggests that patients with current or previous steroid use that have features of exogenous Cushing, such as our patient, are assumed to have glucocorticoid-induced adrenal insufficiency. So who should we consider at risk for glucocorticoid-induced adrenal insufficiency? Is it everyone on steroids, or are there more specific risk factors? So typically patients on longer duration of treatment, so 3 to 4 weeks, any dose greater than the physiological daily dose as well. And remember that the steroid potency as well as the duration of action is an important risk factor as well. So the Endocrine Society recommends against routine testing for adrenal insufficiency in patients on supraphysiological doses of steroids. So if you have a patient on a physiological dose of steroids, or you're aiming to discontinue the steroid therapy, there are 2 options that you can do. The first one is what we generally do clinically, is that we gradually taper the dose and you monitor the patient clinically for signs and symptoms of adrenal insufficiency. The second would be to test the patient with serum cortisol. So you'll do an 8 AM serum cortisol level. If it's more than 300, you know there's been recovery of the axis, and thus you can safely stop the steroids. If it's less than 150, you know the axis is still suppressed. So they suggest you continue at the physiological dose and you repeat after a few months. So glucocorticoid-induced adrenal insufficiency is an important contributor to premature death in your chronic steroid uses. So we need to have awareness of this order during intercurrent illness or following cessation of steroid therapy as well. So we know the incidence of adrenal crisis in patients with primary or secondary adrenal insufficiency is 3.6 to 8.3%, but this incidence is increased up to 15% in our steroid users. In a retrospective study of 300 patients in Sweden who were given steroid treatment at admission, 11 patients, so 3%, had a death that was considered probable due to undiagnosed or untreated glucocorticoid-induced adrenal insufficiency. And the causes with this, they considered, was failure to increase steroid doses during times of surgical stress, inadequate practice regarding medication and admission and discharge, delayed administration of your steroid doses, and missed or delayed alternative administration of steroid routes in your fasted population as well. So in terms of stress dosing, how do we assess patients? So we classify patients as a minor stressor, or do they have a major to moderate stressor as well? So your minor stressor is any illness that is managed out of hospital. A minor surgery, such as a procedure just requiring local anesthesia, even significant emotional stress, such as bereavement, is a minor stressor. Your major stressor is any admission to hospital requiring like IV antibiotics, any surgery, regional or general anesthesia, labor or vaginal delivery as well is considered moderate to major stress as well. So for your minor stresses, we should increase the prednisone to about 10 milligrams a day for 2 to 5 days or until the patient is well. For your major stressor, we start with a bolus dose of 100 milligrams, and then that's followed by 200 milligrams over a 24-hour period. So that equates to 50 milligrams every 6 hours. So in terms of how should we taper the steroids, first of all, we should only attempt to taper steroids once the underlying disease process for steroids is controlled. We don't need to taper steroids if you've only used it for less than 3 to 4 weeks. There's no evidence that a very short-term treatment will lead to suppression of the HPA axis, but there's a lack of high-quality studies regarding this. The first thing you should do was change your long-acting agent, such as dexamethasone, to a shorter-acting agent, such as prednisone or hydrocortisone as well. During this entire tapering process, always counsel the patient regarding stress doses as well as glucocorticoid withdrawal syndrome as well. If patients are on higher doses, you can come down with the dose quite quickly, and as the total daily steroid dose is approaching the physiological dose, then you should taper a lot slower as well. You can consider more rapid tapering in cases of uncontrolled hypertension, hyperglycemia, or glucocorticoid-induced psychosis as well. So currently, the optimal type and dose of steroids to use during the taper process has not been established. And the above is a table from the Endocrine Society, and they suggest above 20 milligrams, you typically decrease the steroids by 5 milligrams every week. From 10 to 20 milligrams, you decrease it by 2.5 milligrams every 1 to 4 weeks. And from 10 milligrams, you decrease it by 1 milligram interval as well. So coming back to our patient, Mrs. MD, as mentioned, she was diagnosed with exogenous Cushing's. And according to the Endocrine Society, if you have exogenous Cushing's, we assume that you have glucocorticoid-induced adrenal insufficiency. And we tested this for the short synactin test. As you can see, she's failed the short synactin test, reflecting suppression of the HPA axis. On reflecting on our presentation, we think the syncopal episode and nonspecific chest pain was secondary to glucocorticoid withdrawal syndrome, secondary to abruptly stopping the steroids as well. So just a quick diagram depicting the glucocorticoid withdrawal syndrome versus adrenal insufficiency. So glucocorticoid withdrawal syndrome occurs due to dependence on supraphysiological steroids. And this is classically seen in patients such as our case presentation who are presenting with Cushing syndrome, and the symptoms appear while you're decreasing the dose of steroids. Adrenal insufficiency will only develop when the overall total daily steroid dose is below physiological levels or level required for adequate stress response. The typical biochemical evidence of adrenal insufficiency is often lacking in cases of glucocorticoid withdrawal syndrome. So just to summarize our case, Mrs. MD was diagnosed with exogenous Cushing's, and this was complicated by glucocorticoid withdrawal syndrome, glucocorticoid-induced diabetes mellitus, hypertension, hypogonadotropic hypogonadism as well. She's currently undergoing a steroid tapering regimen. We did do a DEXA scan, and surprisingly, it didn't show any features of osteoporosis. And thus, our take-home message for today would be only use steroids when there's objective evidence for therapeutic benefit. Choose a steroid preparation, route, and dose that will provide maximum benefit and minimal adverse effects, and monitor your response to steroids with objective criteria. Give the steroids for a duration to achieve desired response, but no longer than necessary. Always monitor for side effects and monitor for features of glucocorticoid withdrawal syndrome and adrenal insufficiency. Okay. Thanks. Do we have any questions?